Welcome, everybody, to my Friday show. And today's topic will be gout and sleep apnea. And we start right now. Hi, I'm Dr. Pete. I have a PhD in biochemistry, and I'm a specialist in the area of gout and also other metabolic diseases that are driven by fructose uric acid metabolism, and in particular, the integration with the polyol pathway. In today's episode, I am happy to say that we have a guest speaker. His name is Burton Abrams, and he will be talking to us about the substantial amount of epidemiological evidence that shows that sleep apnea is a driver of gout. Wait till the very end of the presentation because I will then chime in after the fact to provide a summary of the biochemical evidence, the molecular evidence, non-epidemiological evidence that shows that fructose uric acid metabolism is a driver of gout and other metabolic diseases, number one. And then number two, if you are suffering from sleep apnea, what you should do.
Hi, my name is Burt Abrams, and I'm going to be talking about the connection of gout with sleep apnea based on my own experience 20 years ago. So let me start with what I found 20 years ago. In 2003, I trained myself to sleep exclusively on my side in order to suppress my own obstructive sleep apnea. And ever since then, my increasingly frequent arthritic gout flares ceased. Now, this is called position therapy for sleep apnea. It's one of the things that it sometimes is used to overcome the problem. It is not, it's beneficial for almost everybody with sleep apnea, but it doesn't solve the whole problem for most. Much more is needed. So, word of warning, don't just sleep on your side and assume if you've got sleep apnea, that's going to solve it. You need to see a sleep physician and get it resolved. All right, so to start, I want to make sure that everybody understands exactly what I'm talking about. How do we define sleep apnea? In adults, by the way, there is sleep apnea in children, but it's caused by other problems, and they usually outgrow it. Sleep apnea is defined as the frequent cessation or significant reduction of breathing during sleep for at least 10 seconds at a time, averaging at least 5 such events per hour during the sleep period. So there are frequent periods during the night when you're suffocating yourself because you're not breathing. And eventually, if you continue to survive, which is most of the time, your body will realize you're not breathing, and the brain will wake you to jolt you to start breathing again. There are two major subcategories of sleep apnea. The first is called obstructive sleep apnea, and that's due to repeated transient closure of the airways. During sleep, the muscles relax too much, so they can no longer hold the airway open, and the airway closes up, so you don't breathe. It's very common in adults. In the United States, the best estimates are 34% of men in the US and 17% of women have this condition. Luckily, it's readily treatable. The second type of sleep apnea is called central sleep apnea, which is much less common. That's due to repeated lapse of the brain's breathing control for a transient period of time until the brain wakes up and starts ordering breathing control again. That's much less common, but it's not as readily treatable as the obstructive form of sleep apnea. Here are some of the salient features of obstructive sleep apnea. As I told you, it's very common. In the adult US population, about 25%. It has very serious long-term, often life-threatening consequences if left unresolved, but it's readily resolvable. Unfortunately, it's grossly underdiagnosed. Best estimates are at least 80% of those with sleep apnea have never been diagnosed with it. Now, I'd like to define gout in humans. Unfortunately, this is really a work in progress. Most of the papers and things that I read about gout don't bother defining what gout is. And those that do define it, it's not a uniform definition of it. So I had to try to concoct my own definition, and it's based on two sources. One is a textbook by Turkle and Edwards about gout diagnosis and management. These are two recognized experts physicians in the United States who are recognized as experts about gout. And in their textbook, they define gout as the deposition of crystals of monosodium urate, which I abbreviate as MSU, in body tissues and fluids, resulting from a supersaturated concentration of serum uric acid, that is uric acid in the blood, also called hyperuricemia. Now, it's the supersaturated concentration of serum uric acid, which I've already told you is called hyperuricemia, which can be continuous or intermittent, and it leads to the precipitation of monosodium urate crystals. That is a necessary condition and a precursor for gout to manifest in people who are genetically predisposed to gout. Hyperuricemia is much more common than gout. Most people with hyperuricemia never get gout because they're not genetically predisposed to it. Those who are will get gout. All right, so how in the world would the chronic intermittent hypoxemia, that is too little oxygen in the blood, from sleep apnea, cause the intermittent hyperuricemia, that is too much uric acid in the blood, with the precipitation of monosodium urate, which are the crystals which lead to a gout attack in those who are genetically so predisposed? Well, the first thing that happens is there is an increased influx of uric acid into the blood. That's intermittent. That's occurring during the periods when the breathing is reduced, causing a reduction in oxygen in the blood, which injures all oxygen-starved cells. And these cells then cannot oxidize the food that they rely on from the bloodstream. So they have to sustain their lives, they have to rely on what I call a rechargeable battery in the cell. It's actually a chemical called adenosine triphosphate in the nucleus of every cell. And it begins to undergo a chain of chemical transitions, each of which is producing energy for the cell to use to continue its life. This chain of transitions is called nucleotide turnover. The last item in that chain, it culminates irreversibly in the abrupt generation of excess uric acid to be fed into the blood. The fact that it's irreversible is important because that means when the sleeper starts to breathe again, he's going past the period of apnea, he's starting to breathe again, the uric acid does not go back up the chain. It remains as uric acid to be fed into the blood. The second item is that the uric acid in the blood, the solubility of uric acid in the blood is reduced. That too is intermittent because the episodes of hypoxemia, that is reduced oxygen in the blood, lead to a concurrent condition called hypercapnia, which is an excess of carbon dioxide over oxygen in the blood. Now, carbon dioxide dissolves in the blood, or as it would in water. It dissolves and forms a weak acid called carbonic acid. So that makes the blood more acidic, which means that other acids are less soluble in the blood, including serum uric acid. That is the acid which we know leads to a gout flare. So we've got more flowing in, we can hold less in solution. And the third thing, there's less flowing out because the chronic intermittent hypoxemia gradually reduces the kidney's glomerular filtration rate, which slows the removal of uric acid from the blood. Now, there's also a short-term effect on the kidneys, which also, during the hypoxic period, which also slows the removal of uric acid from the blood. But even over a long term, that remains. And it takes about 3 months of no sleep apnea for that to reverse, for kidney function to be fully restored. So we've got these three conditions. Now, these conditions are present in medical journal literature. I don't know why nobody else picked it up, but I did. I'm able to realize, and when combined together, they're going to lead to the precipitation of monosodium urate. And once the sleep apnea is resolved, these conditions no longer occur. Now, just as I'm telling you how the monosodium urate is formed, an individual acute gout flare typically ceases within 1 to 2 weeks. So what's happening? Is the monosodium urate dissolved? No, it almost never dissolves. And it's distributed throughout the body. But the nascent MSU crystals get to be coated by the immune system, so they're no longer sensed by other aspects of the immune system. So the gout flare does not continue until you've got a new condition which produces more nascent monosodium urate crystals. For those of you who may have had difficulty understanding all the words on the previous slide, I drew up this pictorial analogy of gout resulting from sleep apnea. And in this picture, I'm viewing the blood as a storage container for uric acid as it transports it from where it's produced in the cells to where it's disposed of in the kidneys. Now, we know from what I've said before, the production in the cells is increased due to what's called the catabolism behavior in the cells. Production is increased. The kidney function is reduced, so less uric acid flows out of the blood, more comes in, less flows out. Plus, there's reduced storage capacity. This storage unit, because of the acidity of the blood, is actually shrinking in size whenever you have the conditions leading to reduced oxygen. So what happens when this storage unit gets filled to capacity, can hold no more, out pops a cork, and these crystals of monosodium urate precipitate. Now, the book by Burton Abrams that I referred to before has, I think, a very wise comment in there. The comment is that clinicians should always consider what the cause of hyperuricemia is in the individual patient. Unfortunately, that book does not contain any reference to sleep apnea. Gout is an early warning of sleep apnea, and if the warning is heeded, it allows for sleep apnea's early diagnosis and treatment, which may prevent gout as well. If left unresolved, sleep apnea has many serious, often life-threatening later consequences. If sleep apnea is resolved early enough, the risk for developing those diseases is greatly reduced. What are some of these diseases? Cardiovascular diseases, hypertension, chronic kidney disease, type 2 diabetes, cancer, autoimmune diseases, depression, non-alcoholic fatty liver disease, and others. Some of these may be reversible once sleep apnea has been resolved. Now, just one other diagram here about the prevalence in the US of these conditions. Obstructive sleep apnea has a prevalence of about 25% in the US population. I've told you that earlier. Hyperuricemia, based on reliable sources, also has a prevalence of 25%. So if I'm going to draw a Venn diagram, I would draw two circles that are the same size, one that indicates prevalence of hyperuricemia and the other that indicates the prevalence of obstructive sleep apnea. The only thing that has to be determined is how much overlap is there between these two circles. And that we can deduce from what we know about gout. Among those with hyperuricemia, 20% of those have gout. Among those with obstructive sleep apnea, 14 to 16% of them have gout. When we look at this Venn diagram, we see that the region with gout is most in the hyperuricemia area only. So this gives us an idea of how close we would end up putting these two circles that indicate the prevalence of hyperuricemia and the prevalence of obstructive sleep apnea. Here are the takeaway messages that I want to leave you with. Most gout flares start during sleep. They're the direct result of obstructive sleep apnea's hypoxemia. That is too little oxygen in the blood. Obstructive sleep apnea is very common, but is grossly underdiagnosed. Unresolved obstructive sleep apnea has been associated with almost every non-infectious scourge disease of modern life, accompanied by significantly increased mortality. And those who have the sleep apnea are going to die prematurely. The gout is an early alarm signal for OSA that allows for the treatment of it before its irreversible life-threatening consequences develop. One of the first things that should be done when symptomatic gout first manifests is sleep apnea diagnostic testing, followed by sleep apnea treatment when warranted.
So that was a very important presentation from Burton Abrams. And just to give you a little bit of background, how we got connected was that he saw some of my videos, and this was a while ago. In fact, I think it was almost 2 years ago. And he came forward and said, I think, you have very interesting perspectives about the drivers of gout, but you've left out sleep apnea. And then we started conversing about this. Now, you'll notice from Burton's presentation that it is 100% epidemiological evidence. And one of the issues that comes out of his presentation for me is a chicken and the egg problem, what comes first. And what I mean by that is that what is in fact driving the gout, and I believe that it is central biochemistry that mostly in our space is talked about by calling it fructose uric acid metabolism. These days, I'd actually like to call it something else, because generally the knee-jerk reaction to that, calling it fructose uric acid metabolism, which is driving all these metabolic diseases, this is the central biochemistry, is a conversation that leaves out the polyol pathway. Now, I'm going to be dealing with that in a different video. What I want to focus on today, and I'm only going to summarize it, is what I think the basic hypothesis is. And this is a hypothesis, but the molecular evidence, which is non-epidemiological, points pretty strongly at what I'm talking about. So let's just dive into this quickly. So over on the left side of the slide are the drivers of fructose uric acid metabolism, assuming the importance of the polyol pathway. The fructose uric acid metabolism with activation of the polyol pathway has been shown unequivocally to be in pancreas, liver, muscle, adipose tissue, brain, and also in the chondrocyte, which is the biologically important cell that is in our joints that participates in generation of the gout flare. The drivers of this particular metabolism, if you will, is hyperglycemia, added sugar that brings in both glucose and added fructose, fructose directly, umami, which is an assortment of substances, including high levels of glutamate. The public knows this as monosodium glutamate or yeast extract, in addition to adenosine monophosphate and inosine monophosphate. And then lastly, and no less important, alcohol. And when these substances are present in a combinatorial way, or even individual, in the case of fructose, they will open this metabolism, and this metabolism causes a metabolic shift in state from what I call the white state, which is dominated by burning, a mitochondria that is intaking substrate and producing ATP as a result of it, along with other small molecules that participate in the generation of substrate that can be used to do things, to energy for the organism to go about whatever its daily life looks like. When we have the input of these substrates, either individually or together at concentrations that are high enough, we have establishment of what I call the red state. And this is an actual metabolic state. It involves profound changes that happened at the level of the mitochondria, and it involved the storage state where we're producing and storing fat and glycogen and water. We have a significant elevation in systemic inflammation, which from the point of view of evolution of humans was important to stimulate the immune system. And we have an alteration of the nitric oxide system. And then depending on the organ you're talking about, the alteration of nitric oxide has serious consequences. When we generate the red state chronically, then this becomes the driver for the full list of metabolic diseases: type 2 diabetes, obesity, the gout condition, Alzheimer's, chronic kidney disease, and so on down the line. Now, what this has to do with sleep apnea are in two main areas. The first at the top, I write there, alterations in the dental arch and soft structures. This is epidemiological evidence. Back in the 1900s, there were a number of different doctors that studied the metabolic condition of native populations that were isolated from the Western diet versus those same populations that had actually integrated into eating the Western diet, high sugar, white flour, and rice, and so on down the road. There are numerous, in fact, hundreds of these studies that were done that showed that from a physical point of view of these two populations, could be seen in a narrowing of their dental arches, a deeper clustering of the soft tissues in the back of their throat that at that time were proposed to lead to breathing issues. Down below in the red circle listed brain, there's molecular evidence that the polyol pathway is active in brain centers that control sleep. So again, this is a hypothesis that I'm talking about. I don't think it is accidental that when we look at type 2 diabetics, people that are obese, and people that suffer from gout, that such a high percentage of us also suffer from sleep apnea. And I think that the biochemistry that we're talking about here is central to it. Now, one of the things that gets really complicated out there in our space is the discussion of the chicken and the egg. There's a lot of scientists and medical doctors that say that, once somebody becomes obese, that obesity is driving the diabetes and so on. I'm arguing that, in fact, it's the central biochemistry that when it is activated on a chronic level is generating these diseases. Once we have these diseases in place, however, they also generate their own pathologies, and there is significant crossover between them. So once somebody becomes sleep apnea, they are, as adults, they are showing this in part because of the physical narrowing of the breathing pathways, but also in part because of the dysfunction that has been driven at the level of the brain. We have these hypoxic events that are happening where you will actually pause your breathing numerous times throughout the night, which causes an elevation in the hypoxic environment, which biochemically is known to activate fructose uric acid metabolism. So the point is that once you're in this condition, the sleep apnea itself is contributing in a vicious cycle to actually making the situation worse biochemically, which then has the function adding momentum, if you will, to the biochemistry that's driving these pathologies that ultimately shorten our lifespan and increase the level of all-cause mortality. Now, the question is, if you are suffering from various metabolic dysfunction, and I've produced a lot of videos in this area, and in particular gout, and you have not been sleep tested, you need to get sleep tested. A lot of people believe, laypersons, that, well, I don't snore, so I can't have sleep apnea. Well, this is not true. A lot of people suffer from sleep apnea who don't snore. This is critical that you actually get tested, especially if you are suffering from multiple metabolic disorders. For example, in my own case, I was suffering from gout and also prediabetes. And it turns out when I got sleep tested, thanks to a conversation that I had with Burton, that I had sleep apnea. So get tested. You need to know if this is the case, because it is a dangerous situation to be in. So you get sleep tested, let's say it's positive, then what do? Number one, you eliminate the drivers, but I believe this is being driven fundamentally by the hyperglycemia, the added sugar, the umami, the alcohol consumption, and so on. You eliminate the drivers. Next, you want to think about sleep position. And if you sleep on your back, you need to alter that. Start learning how to sleep on your side. I've even talked to some people that have flipped the position onto their stomach. But if you're like me, sleeping on your stomach is out of the question. So sleeping on your side will be an improvement, because it optimizes a gravitational situation where the soft tissues will tend to slide forward rather than back into the back end of the throat, causing a constriction of the airway. Position alone is not going to reverse sleep apnea. Position alone will not reverse sleep apnea. I said it twice because in the discussions I have in electronic forums and also with clients and extended family is the pushback against eliminating the drivers. And then when we talk about the sleep apnea, right away I hear, well, I've learned to sleep on my side, so it's not an issue. All right, position is not going to fix this. It will improve the situation, no question about it, but it is not going to reverse your apnea. So what do you do next? You have options. Everyone has probably heard of the CPAP, and almost nobody wants to do it, including me, because of the intrusiveness of it for you, and then also whoever is sleeping with you. Whoever else is in the bed is going to be disturbed by the discomfort you're going to have and the noise that the machine makes. Are there other options? Yes. I utilize a mouthpiece. One of the key things that you want to do after the intervention, then you go back and you get sleep tested again. And what you're looking for there is for the complete reversal of the apnea. So I got myself one of these mouthpieces. Then after using it for 2 to 3 months, getting used to it and so on, then I went back and got sleep tested, and I've reversed my sleep apnea at this point. There are also implants that are now available on the market, and you can explore that. In my way of thinking, having multiple interventions is a good idea. So I use my sleep position and also the mouthpiece. If I was to go the implant route, then I would also be exploring the mouthpiece and using them together potentially, because it's really important to eliminate sleep apnea because of the hypoxic events that it generates. The fact that hypoxia activates fructose uric acid metabolism, which also drives these chronic metabolic diseases that I talk about frequently in my videos, and the fact that it drives the gout flare. And if you're interested in asking questions, you want to find out more about these topics that tend to affect all of us, especially in the crowd that is 60 years old or older, here's my email address. Also, you can find me at www.drpetent.com and also at www.drpetescoutintensive.com. And now I also have a Patreon account where I have taken all of the most important lessons that I teach in the Gout Intensive, and I've made this available for a very economical price to the general public. And I'm updating that account all the time to make sure that you have the tools that you need in order to put your gout in remission. Thank you very much.